Good morning, good afternoon, good evening to all of you, wherever you are. My name is Michel Goldman. I'm the co-director, together with Mathias de Watripon, of the Institute for Interdisciplinary Innovation in Healthcare at the Université Libre de Bruxelles. Thank you so much for joining us to follow this conference debate, organized as part of our interdisciplinary educational program, a program that gathers students from different backgrounds, biomedical sciences, bioengineering, and public health, but also economics and other social sciences. What they have in common is a keen interest in health. In this disrupting and uncertain time, there is still one certainty. Overcoming the crisis primarily depends on the young generation. Both short-term, to prevent spreading of the virus, to maintain healthcare facilities functional, and long-term, to put in place new ways of living, to foster and implement new strategies to prevent and tackle pandemics, as they do so well for climate change. This conference debate was organized for them, but also for all of you who are wondering how we will get out of this crisis. Before giving the floor to Vanessa Costanzo, who will be our moderator, I would like to express my warmest thanks to the Bayer-Latour Fund, who is supporting our program since the very beginning, to our partner Frontiers Media, an open access publisher, and of course to our guest speakers who accepted to join us in these exceptional circumstances, some of them on very, very short notice. Vanessa, the floor is yours.
Thank you, Michel. Good morning, good evening, everyone. I hope you are comfortably seated and ready to interact with us. As you can see down to your screen, you have the possibility to ask a question to our speakers. As Michel Goldman just said, the purpose of this conference is to take a step further and to offer guidelines and ideas based on scientific studies. So to make it very clear, and just for a short second, we are not here to criticize, we are not here to judge, and we are not here neither to make politics. So please be kind, be positive, and we'll try to answer as many questions as we can. So let's start with this question. As you have seen on the invitation, we refer to COVID-19 as a systemic crisis. So Mathias de Watripon, hi, you are one of the co-directors of the I3H Institute. You are professor of economics and also former vice governor of the National Bank of Belgium. Why, Mathias, is this pandemic a systemic crisis?
Well, thank you, Vanessa. Hello to everybody. Well, I think it's pretty obvious that this crisis is global. Today, you have billions of people confined. This, of course, in terms of economics, beyond the most important part, of course, which is the life and death things and the health. You see that also you have the biggest contraction of economic activity since World War II. That means it's a much bigger, potentially, than the financial crisis. Yesterday on the page 1 of the New York Times, you had this picture about jobless claims in the US per week. And in the last 20 years, the financial crisis had the highest number, around 500, 600,000. Yesterday, last week, it was 3.3 million. Now, the key will be, of course, how long this economic crisis will last, whether there will be an accompanied financial crisis. It is crucial to be able to get the situation under control so as to restart the economy. Otherwise, the implications also for the whole health services and so on will be also catastrophic.
Okay, before we go further, Michel Goldman, let's get straight to the point. Today, everyone is busy, as Mathias said, to handle the crisis, to find also day-to-day solutions. What you want is to take one step further and to start getting ready for the end of the containment. So Mathias and you, we can say basically you have a plan.
I don't know if this is a plan. What we see is that, this crisis starts in a completely unexpected manner. And this explains why countries reacted differently. That's why some, containment procedures were introduced very early in some countries, very late in others, why testing was intensive in some countries, not in others, etc. I think that what we should do now is really to prepare the next phase. We are all waiting to get out of the lockdowns, of the containment procedures. And here we can anticipate because the situation is basically the same in, for example, in Europe, across all member states. So we will get out of the containment probably certainly at different times, but the process should be quite similar. There is no reason to a different process. The virus is the same, the problems we are facing are the same. It will not be that easy to elaborate this strategy. And that's why it will be complicated. We have to start early so that when the day will come, we will be ready.
Matthias, I'm coming back to you because before we go into the scientific and the technical details, tell us why this has to be considered an investment by the government and why also this has to go beyond Belgian borders.
Well, first of all, this idea that Michel mentioned that we have developed together also with Jean-Philippe Plateau and Eric Muraille about having as fast as possible after the peaks of the crisis, double testing of individuals to show that they are not infected, but they had the contact with the virus and have developed immunity, then they could go back to work. Because, the key is how do we go from a place where a time where everybody is confined and can see nobody to a time where everybody can go to work together. So it will be very important to make sure that people be reassured that they can do it. And compared to the trillions, literally trillions of dollars or euros that are being spent on softening the impact of the crisis, this is a small amount of money that would be indeed an investment that would be extremely profitable, not only from the point of view of health, but also from the point of view of the public finances.
Mm-hmm. Thank you, Matthias. We have with us Jean Tirole. Hello, Jean Tirole. You hold the Nobel Prize for Economics in 2014. You teach economics at the Toulouse School of Economics. You are the author of a bestseller book titled The Economics of the Common Good. The vision that you have developed, Jean Tirole, in this book has probably never been as relevant as today. So how might this vision, this economic vision of the common good help to address the COVID-19 crisis?
Well, thank you so much for having me. If we want to think about the crisis, we have to go back, and the common good, we have to go back to an old concept, which is a veil of ignorance. It's a very simple question. If you didn't know, who you will be in terms of man or woman, or if you'll be in good health or bad health or whatnot, if you'll be Belgian or French or something else, in what kind of society would you like to live in? And that very simple question already brings a lot of answers about the role of the state, which is state is there to align individual interests with the common good. So for example, you would like to fight externalities like climate change externalities. You would like to have competition policy, and you would like to have all kinds of insurance devices against the risks that you may face in life. So, for example, the health risk, it's not your fault if you have a cancer or if you end up being sick in many different ways, and therefore you want to have insurance against that, universal health care. You want to have some kind of redistribution, equal opportunity, and so on and so forth. That's the second thing. The third thing that comes out of this analysis is, of course, the role of the state, of the government, as basically a lender of last resort. So not only protecting fragile individuals, and we see it now, of course, with COVID-19, but also going further in protecting firms, protecting banks, for protecting countries, because after all, that's not their fault if the firms cannot no longer operate, the banks are losing money, and the countries are in a terrible state financially. But this being said, there are of course concerns, which is that in terms of the countries, that's going to be extremely expensive, especially if the crisis lasts very long. We have countries which have been very short-sighted, and their overall level of on-balance and off-balance indebtedness is very high, much higher than 2008. And now we face in Europe, especially in Southern Europe, by the way, I will add France and Belgium to Southern Europe, some kind of difficulties. And that's why I think it's particularly important to put the money where it's really needed. And also to do exactly what Matthias and Michel are proposing, is trying to find ways of getting people back to work as soon as possible, of course, consistent with health considerations.
Jean, I will come back to you. And first, I will ask a question to Michel Kazatchkin. Michel, you are in Switzerland, in Geneva, and you are joining us. And so you have been the executive director of the Global Fund to Fight AIDS, Tuberculosis, and Malaria. This pandemic seems to be monitored by who? By the EU, but handled, as Jean Tirole just mentioned, very differently in each country. So coordination is very perfectible, and I know that you have something to say about that. We cannot hear you.
Microphone.
Yep. Good afternoon to everyone. Sorry. I guess everyone can easily understand that getting an epidemic under control requires governance and coordination at all levels, national and global. We need coordination to put in place the public health measures, to develop therapies, to develop vaccines, to minimize the social and economic impact, just as was discussed by Matthias and Jean Tirole. Yet, if I look at COVID-19 today, what I see is a global picture of cacophony and discord, one of lack of global governance and coordinations. Countries do what they want, including sometimes doing what may appear politically expedient to them. And there are at least three factors I can see to that. One is, as mentioned before, our unpreparedness and late reaction to the pandemic, so that countries keep focusing on their own most urgent problems, not looking at mid and, of course, long term. The second is that, unfortunately, we do not have an effective governance mechanism in global health. Coordinating responses to health emergencies is in the core mandate of the World Health Organization. However, everyone can realize that declaring COVID-19 a public health emergency of international concern had really little or no power, because countries at this time are not willing and not ready to give the World Health Organizations, or in Europe, to give the European Commission a mandate of intervening and a mandate to have countries be fully transparent and accountable for what they do to the global community. And that, unfortunately, and that's my last point, is happening on a prevailing climate. I think everyone will agree to that, of fading global solidarity, increasing unilateralism, nationalism, sovereignism, declining trust in multilateralism, a background of mistrust, misinformation, challenge of evidence as basis for public policy, and increased politicization of health. So there are significant dangers to this global mistrust and lack of unanimity. I hope this is not too late to change directions. We'll come back to that.
Thank you. Jean-Tirole, I'm back to you because I think you have something to say about that. Is this lack in preparation, and obviously it's been the case everywhere, so there's nothing to criticize, but was this lack in preparation maybe something that we can change and that we will have to study for the next pandemic, also to avoid economics burden, as we know at the moment?
Yeah, first of all, I would like to say I agree with everything which was just said. I mean, we have this issue that national interest is completely paramount nowadays. So every country for itself, and we see that in many other directions, like nationalism, protectionism, and so on. So that's the life we live in, unfortunately. And but you have another question there. It's not only national interest; it's a lack of preparedness. We actually are very short-sighted, and this is linked with the political process, of course. The political process is very short-sighted, and all the issues which are long-term, like climate change, like research, like education, like those dimensions of healthcare are neglected, and for good reasons, in a sense. And the same thing with debt. Debt is a long-term issue. Who cares in the short run? So that's a problem with the political process. It has been recognized for a long time, but pretty clearly we need to do something about improving the governance so that we can actually have an advocate for the long-term view. But it's difficult because in climate change you get exactly the same two factors. You see in climate change the nationalism, everybody wants to free ride on the others, and you see the short-termism, which is, the future generations don't count in a sense. And in healthcare, you see some of that. So we need to change institution and also convince people actually that that's needed if we want to survive. It's not, obviously climate change is an issue, but also the epidemics, the pandemics is also an issue. And it's not only the COVID-19, it's, if you think about the permafrost, if you think about biological warfare, antibiotic resistance, and so on, we have to solve those issues, right?
Vanessa, your micro.
I'm sorry, I was mute. So, Michel, I'm coming back to you and to this serological test you are proposing with Mathias de Watripon. Here also we can see that there is a lack of organization at the moment, at least at the European level. We are still far from the solution.
Yeah, because before coming to these serological tests, I think there is a regional, general problem. I think that we have in Europe the best experts in virology, in immunology, in epidemiology, in pharmaceutical science, in vaccine development, both in universities, academia, and in the industries. So we have everything in place to really take a lead in fighting this crisis, developing the treatment, developing the vaccines. But it's clear that the first step to go out, to exit the current situation, is indeed to have tests, to safely reintroduced in the normal life and in the workforce. So we need collaboration. And Europe has a tradition to foster collaboration. Myself, for 5 years, I was the executive director of the Innovative Medicines Initiative, which indeed bring together the different sectors, private, public, regulators, patients, organizations. So it's feasible. The point is that we need to invest enough in this collaborative approach. IMI is currently indeed developing projects, but the financial resources allocated are not sufficient. And also perhaps the degree of integration is not sufficient. This crisis is dramatic. We have to change the way we operate. And if competition can be good between universities, between industry in most situation, I think in this situation, which is really unprecedented, we have to act differently. We have really to have everybody working together. And this is where I hope that the Commission and the European Union will be creative. Current instrument, I mentioned the IMI, can be used. There might be other, even as I said, more integrated to be created. And also I think it's very important that the Commission understand that they have to gather, to convene the best experts all over the world, whether in Europe or elsewhere, to define the strategy. And in this strategy, it's true that the serological tests are important.
We are going to try to connect with Marius Gilbert. Marius, can you hear us and see us?
I can hear and see you. I'm not sharing my screen.
I don't know if we can see you on the network, but anyway, we will try to have a small intervention with you. So Marius, you are the director of the Spatial Epidemiology Lab at ULB. And I guess this option that Michel was talking about means to have a lot of data to monitor. Do you have at the moment the capacity to monitor all these tests and all this data which is going to come?
But there is also lots of variation in, let me try to just to share my screen if the bandwidth
much
allows.
better.
There's also quite a lot of variation between the country in the level of testing. So the data that we receive is very variable from country to country. And the other thing is that different countries also have different policies when it comes to sharing the data. So the lack of harmonization that has been previously mentioned also applies to the testing policy. So what we see in Germany is completely different from what we see in Belgium or in Italy when it comes to detection levels. Also, the access to the detailed data is also different between country and countries. So there's this lack of harmonization is also a problem when it comes to the huge volume of data that we have to assemble and process in epidemiology.
What can we do? What can you request at the moment just to solve the solution? Should it be a European process also?
Well, ECDC is making general recommendations, but since health is down to the national countries, they can follow or not those different recommendations. So the reality is that what we see in terms of data differ very, very strongly from countries to countries.
Thank you. We'll go to see Hugh Bersini. Hi, Hugh. You are in Brussels, and you are a specialist of AI. If you are here today with us, it's because we have a question maybe we can ask is that AI is basically at the center of everything. It's everywhere at the moment, but it just looks like that in this crisis, it is not a tool at the moment. It is not an actual tool. It will be maybe the next weapon we will use.
Well, AI in digital technologies in general, if it was already the only vital use of the internet and all the communication application it supports, it will have escaped nobody how much digital technologies have become essential to us facing this sanitary crisis. In fact, we will remember that the internet was born during the Cold War in order to make possible, but above all, reliable, threat and communication. But for AI, just specific to AI, yeah, I think AI can contribute a lot, perhaps in the close future. Big data and machine learning components should make it possible to find finely diagnosed lung X-rays. If we agree to share, and it's exactly the same problem that Marius was just mentioning, if we agree to share the multitude of new medical images that the crisis is bringing about, clearly many barriers will have to be removed once and for all. Faced with a very unequal disease in terms of impact on people, it should make it possible to better understand again, by mixing the, unfortunately, enormous mass of available data, what are the most discriminating attributes, like we know that age, sex, disease, habitat, lifestyles is impacting a lot, and with AI, which can try to be even more precise in finding those discriminating attributes, which allow to better predict both the risk of contagion and the nature of the evolution of this disease for those who have it. And it's more decision-making and more expert system, the old-style artificial intelligence. It should allow to a better diffusion and greater efficiency of diagnostic, therapeutic, and preventive practices. For instance, finding the doctor most able to receive you, as well as tomorrow, as Michel was wondering, as well as tomorrow, the test center and the best schedule for you. It also allows for the more diffuse and efficient implementation of the many social regulation measures that our governments are putting in place. Your smartphone can alert you to your health and help you to take care of it. It can alert you to anyone approaching less than 1 meter, possibly the risk of contagiousness. It can also inform, if we want it or not, that is another issue, the police of your position and distance from your home, your possible regroupings. Yeah, AI has a lot to bring.
Thank you. I will go, and it was not supposed to be this way at this time, but I think maybe you will have a reaction to that. Odette Wekwart, if you can join us at the moment. Odette, you are a specialist of the reaction, how people react, and you work in Germany at the Max Planck Institute. Do you have an opinion about that? How will people react when governments and everyone will try to track them, even if it's for their well-being? What will be the reaction of the people?
Well, this is a good question. Coming from the field of evidence-based medicine, I have to say we don't have any sufficient study which would tell us how would people react. Right now, it seems that people are very willing to give a lot of private data from themselves to the government because they think it is for the sake of our health or for dealing with the crisis. Given the unstable evidence, or given the evidence we have, or better to say the lack of evidence or lack of data, it is a bit impressive that people right now are quite willing to give a lot of information away from themselves. So it's hard to forecast. I mean, this is a very recent situation, and a lot of urgency is felt in the situation right now because it is so recent. The question is when it goes on with all the different things. We talked about economy today already and other things. Right now in Europe, people or European countries are locked down for, let's say, 4 to 3 weeks. This is probably a situation which is bearable. But when it goes on, and the more the government may want you to reveal from you, so in our country, the Minister of Health thought about tracking your mobile to see who you have been in contact with. And this is infringing quite a lot of people's privacy. So we have to see where this goes. Right now, I think it seems people, citizens, and also politicians are kind of under shock. So they behave a bit like, they are quite defensive in their decision making and always behaving as if they see a real disaster coming around. And current data don't allow this conclusion at all right now. It can be, but there's also a chance, and this is not a very small chance, there's also a realistic chance that this virus might behave globally like kind of a normal virus, a seasonal virus. We have to see, we don't know yet, we don't, too little.
Mm-hmm. We'll go back to Michel Kazakhstin briefly, a reaction, Michel.
Yes, thank you. I just wanted to comment here on the fact that it seems to me it's very important that citizens are associated with the political decisions, such as decisions on confinement, not just experts. We have lessons from HIV/AIDS here. You can't impose on people to change behavior or use condoms. You have to call on them to have responsible behavior. And to me, the longer the decisions will be somehow imposed top down on people, the more difficult they will be to accept. So I really call on governments to build sort of councils, discussions, open the debate so that citizens are associated with these difficult decisions.
Yes, Odette.
Yeah, so I have to agree to what just have been said. That is indeed true. And that would be the moment also where people could ask for what is known and what is not known. So the longer the situation goes on, I think the more we require politicians and also people to be educated about the risk and also about how to deal with the risk. So how can I deal with the information? How much do I need to fear it? And when I understand how to work with risk information, and this is something we discussed in earlier panels already, that this is something we need to teach people already, or pupils already at school. So more I'm learning about dealing with it, I also understand why I fear situations, and do I really fear or need to fear the situation, how to behave more reasonable. So there's certainly many things we can do in this situation, reasonable situations. And for behaving reasonable, we need people, but also politicians who are able to deal with risk information, but also with the situation of uncertainty. So understand that it's not only black and white, but that there are a lot of shades in between, and that to discuss this openly with the citizens is an important thing to educate them and make them more aligned with governmental decisions.
We will meet Hélène Toon. Hélène, you are the Director of Medicine Law and Policy, and you are the founder of the Medicine Patent Pool. Today, everyone is looking for the golden formula. Can we make sure that all the drugs we will probably create in a few months, we hope, we expect it to be in a few months, that they will be available for everyone?
Thank you. Thank you for that question. Thank you for involving me in this in this meeting, in this conference. The question you asked is a very, very important one, and we've already seen in this very short duration of the crisis a number of conflicts around access to medicines. Though no proven effective treatment is available at the moment, but already some conflicts have broken out because countries try to procure from sources that no longer exist, difficulty finding alternatives because there are patents on those drugs. Israel recently issued a compulsory license to be able to procure lopinavir, ritonavir, an HIV drug that may be used or at least is being tested for use in the treatment of COVID-19, and it's a little bit of the déjà vu, because we actually went through all of that with HIV, where we had the very sad situation when effective antiretroviral treatments became available. It took more than a decade before those medicines reached people in low and middle income countries. A lot of barriers had to be overcome, and that's of course where the Medicines Patent Pool helped a great deal, but that was more than 10 years into the situation where medicines were actually available. Now today with this crisis, the situation is such that we don't have the medicines, we don't have the vaccines desperately needed. There are vast amounts of money, public money, and money from charities being poured into the development of these new technologies. But what we don't have is a system to make sure that the usual barriers for scaling up are out of the way when these products become available. We can have such a system in place. We actually know how to do that. And as we speak, proposals are being made at the WHO to establish an international mechanism, an international, what you would call the COVID-19 essential technology pool, or whatever name you want to give it, but where rights to data, to knowledge, to intellectual property, whatever it takes to produce and scale up the production of these tools are available for anyone who has the capacity to do that, to use. That would be good for science, it would be good for production, and it would of course primarily be very good for health. I stop here now, but I would like to discuss in a bit greater detail, because as Michel Kazachkin will also recognize, we actually have a lot of knowledge and a lot of experience that we should not reinvent this time around, but should apply much faster than we did the last time around.
I will talk with Michel Kazakskin in a few minutes, but before that, I would like to reach Michel Goldman. So Michel, as we said just at the moment with Hélène, there is a high pressure on the shoulders of the scientists and the doctors. There's also a pressure on the market, on the scientific and pharmaceutical market. At the moment, everyone is trying to find a treatment, and hydroxychloroquine is used by many teams, but up until now, no real scientific study has been made. So can we summarize which are the most promising path and promising strategy maybe to find a cure in a few months?
Of course. So there are two main strategies. One of the strategies is to use existing drugs that are used for other disease, and to see whether they can help to fight COVID-19. One example is this hydroxychloroquine. There are other examples, for example, drugs that are used against HIV, a drug which has been used against Ebola. So those drugs are there, they were tested, especially for their safety. It means that if they are effective against COVID-19, they could more rapidly reach the patient, although there will still be a problem of producing these drugs in sufficient amounts. The point with hydroxychloroquine is the following. The idea that hydroxychloroquine can be antiviral is not new. You know, in 2004, actually it's a Belgian team at the KU Leuven already demonstrate some antiviral activity. There were some trials in HIV, it doesn't really work. So for the time being, this drug, which for some time has been used against malaria, at this time is mainly used in rheumatic disorders. Now, the point is that it is tested on the basis of a few patients who seem to answer positively, and on the basis of in vitro data, laboratory data suggesting that indeed the drug can be antiviral. The point is that it's essential that when we give this drug to the patient, and we can understand that we want to do something, we have a potential drug, we want to give it, but we want also to be sure that at the end of the day, we will be able to say this patient was saved because of hydroxychloroquine. And this required some form of study, some form of trial. And what is really nice is that in the French study, the discovery study, we combine this requirement for a strong scientific basis and the idea to give the better chance to the patient. So this is the so-called adaptive trial studies, in which while the studies is conducted, once you identify a potential drug, you give this drug to more patients, and the opposite, of course, when a drug is not shown to be effective, you just delete it from the trial. For this, you need very strong biostatisticians. We have them, and I think that in a few weeks from now, we will have the first data which will allow to tell us whether this drug has really an action, yes or not. If we don't do this, it means that we will never know, and when we will have to face the next pandemic, we still don't know if hydroxychloroquine will be useful or not.
Michel Kazakskin, I'm coming to you because we will talk about vaccines also. Can you also summarize for us what is made at the time for vaccine, and what can be the most winning strategy in this matter?
Well, thank you. We will have a vaccine. I think the scientific community is pretty confident about this. Because we know that people who recover from COVID-19 develop antibodies, and that these antibodies can neutralize the virus and protect from infection. Just as in many other infectious diseases, let's say measles or seasonal flu or whatever. So we also know that we can develop vaccines against viruses that share many similarities to the virus that is the causative virus of COVID-19. For example, the world has produced a vaccine against SARS. So this is why at this time, I'd like to say that it is most important that we buy time in order to give us the time to develop a vaccine. And the confinement strategies that currently are imposed to people are there to buy that time. There's already one vaccine in phase 1 in the US, and there's a number of candidates that are about to enter phase 1. Phase 1, as you know, is studying whether the vaccine is safe to administer. That will take 3 to 4 months. Then we go into phase 2 to 3, that is looking at the efficacy or for an efficacy signal of that vaccine. That will take maybe 6 to 8 additional months. And once we have a positive signal, one of the challenges that we will have is to have the vaccine ready somehow for dissemination. And this is why we actually have to start producing it, maybe even before we have an answer on whether it's effective or not. And that's, of course, a risky thing to do. But think, you know, we now have a vaccine for Zika, but there's no more Zika. We have a vaccine for SARS, but there's no more SARS. So that timing and that risk-taking strategy will be a very difficult issue in the current epidemic. But let me just say that overall, I'm fairly confident, again, in the fact that we will have a vaccine maybe in 1.5 years or so. And I find across the world a remarkable mobilization of researchers, either on vaccines or, as Michel Goldman just spoke about, on drugs. There are now several hundred clinical trials of medicines going on across the globe.
Thank you. Michel Goldman, you want to react to this?
Yeah, I want just to say that we will have a vaccine, and I'm quite convinced we will have a treatment. The science is there. It's a problem to exploit the existing platform. There are many platforms to screen for antiviral drugs. So I'm quite optimistic. It's a question of time, but I think that scientists so far did extremely well. When you think, you know, just in a few weeks, the virus is identified, the diagnostic tests are developed, and I'm quite sure that the treatments will come as well as the vaccine. The problem will be to implement, will be to produce the vaccines, to produce the drugs in good condition, in sufficient amount, to organize the distribution, and to make the right choice in terms of facilitating access of the drugs, of the vaccines to those who are waiting for them.
We'll go back to Germany and to the Max Planck Institute. Odette Wekwart, you work in the Center for Adaptive Behavior and Cognition. So I think you can basically anticipate some of the reaction. And I know that you are very keen about the reaction of the people when it comes to vaccine. And so we have seen over the past 5 years that even more that anti-vax movement was growing up. And so how do you think people will react when there will be a vaccine, but how will they react? Will they take it? Will they use it or not?
Very good question. Thank you. So I think the anti-vaccine movement, just to put that first, that develops by a paradox or by a phenomenon that people don't see the risk of the actual disease anymore. So taking measles, for instance, due to the effective and safe vaccine we have, and due to the fact that we vaccinated so many people in various countries, most of the people don't experience the risk of having a measles disease anymore. And this fact leads then to people overreacting to potential side effects of the vaccine itself, which are compared to the risk of the disease are harmless. So it comes again down to how well do people deal with risk information, with probability information. So the risk of having something and then I have a vaccine, and how does the risk changes in comparison to this vaccine. And right now I'm very optimistic when we get a vaccine for COVID-19 that people certainly will take it, because now the risk of the disease itself is so much present. Over the years, maybe let's imagine for a second that this is a virus in contrast to, as Michelle just said, SARS, for instance, which persists. So it will come and will remain. So it is really important to have the disease. Over the years, the more people we get immunized by the vaccine, the risk of the disease itself may become less present. And then people will more and more forget about the actual threat of the disease, and then attend more to the potential side effects or risk of the vaccination itself. So again, I think what is really important is that we start teaching our school kids, that we start teaching in universities the mathematics of uncertainty, of risk, that people learn to understand risk information and also to understand which bits are maybe missing in my current calculation. So with the anti-vaccine movement, they just miss a very important risk, the risk of the measles infection itself. And here for this COVID-19, it may go after many years in the same direction, depending on how effective the vaccine will be. But my hope is that the more risk literate people are, the more likely they also are to understand how to combine the different information needed to understand what makes an effective prevention in this and in this sense here, vaccine prevention.
Helene Thun, when we talk about putting a vaccine on the market, obviously we also talk about patents. How can we make sure that this will not hamper the process?
Thank you. Yeah, that's a very good question. It applies both for medicines and vaccines. And I think what we need is an international action, an international approach, governments coming together and say, look, we're spending all this money on the development of the vaccines, of new treatments, but at the same time, we need to start planning for the production of the potential promising products that are coming out, and patents or other forms of intellectual property, because the patent is not the only one that might pose problems. We need to make sure that they're out of the way. And let's not start with that once we know which drugs. That system can be put in place now. Those commitments can be sought now. Those that are in the business of development. It's very interesting to see how in the world of science, this is done in a much more open way and a much more sharing way than we've ever seen before. But that principle of sharing of this knowledge needs to be pulled through into also the production phase. And that needs a deliberate action, because we already see some companies being very proprietary about their knowledge or about their products. As we speak in the Netherlands, my country where I sometimes live when I'm not here, there is a shortage of tests, and most hospitals use the Roche machine for testing. There isn't enough of a particular product and particular fluid that is necessary. It could in principle be made by others than the company that provides the machine, but the company refuses to share the specifications of that product. So it blocks knowingly and deliberately the scaling up of testing. That is becoming a big political issue in the Netherlands. And this is just one example of how things should absolutely not go. So again, this needs to be solved in a spirit of solidarity. I very much like the fact that WHO called the big trials that they're coordinating, that they gave it that name, solidarity, because that's exactly what we need, solidarity, not conflicts. or appropriation of that knowledge. And I hope very much that WHO will take the lead in this. It can work with the medicines patent pool on this, because the medicines patent pool has a lot of experience in how you do that. Also, how do you interact with rights holders? Because it's not a given. You can say, come on, give me your intellectual property. But for corporations, these are the crown jewels. That does not happen without just asking nicely doesn't always work. What does work is very strong political leadership and government saying, this is what we want to see these various actors do. That's one thing that needs to happen. The other thing that needs to happen is that funding agencies, funding entities, be it charities or governments, or the European Commission for that matter, should put conditions on the financing that they give. And they should say, if you develop a product, knowledge, data, whatever it is, with this financing, you have to commit upfront that will be available, so that it cannot be hampering scale up of production of products. So I'm a great, I like the idea of this international COVID-19 technology pool, and I think we should work together to make that a reality. And I have the feeling it is gaining grounds, even though the idea is only 24 hours old.
Mm-hmm. Michel Goldman, I see you reacting.
I think that it's there is one important thing which is important to mention, is the current importance of China .
Can you hear Michel well? Because I don't hear him well. We'll go back to him immediately in a minute. But before we go to Michel, the time he can do something with his Wi-Fi connection, maybe we can go see Marius Gilbert. So Marius, you are an epidemiologist at the ULB, and I know you are monitoring the crisis like every day. So data and key data today is the number of people who are infected, the number of people hospitalized, and also, unfortunately, the number of dead patients. Do you think, Marius, all this data will be helpful to make ready for the next pandemic, and maybe to make ready? We still said we don't know if this is going to be a seasonal process, but if it is, will it be helpful for the next season? We cannot hear you.
Yeah, I had that muted. When it comes to preventing pandemics, I think we really have to go back to the origin, and the origin is animal origin, and we have to work more closely at the human-animal interface, because if we can prevent things in the first place, we can, we don't have to deal with all of those secondary developments. And I think one very important thing is to turn early warnings into public health actions. And Michel is perfectly right in pointing at China in that regard. A few years back, there was the H7N9 avian influenza virus circulating in poultry in China. And for 4 years in a row, China left several hundreds of people to be infected by 7.9, with a case fatality rate of around 30%. That's far more than what we have with COVID-19. And at each of this time, they were running the risk that transmission, there could be human-to-human transmission. And it's only when this virus became highly pathogenic in poultry, and that it had an economic impact on the poultry industry, that they implemented mass vaccination. And that was the end of H7N9 in human health. So collaboration between the animal health and the public health sector is key to prevention of those pandemic that takes their origin into the animal reservoir, and also looking at the interface between human and animals. And that's probably the best prevention we can do to prevent future pandemics, because many of those emerging viruses have an ultimate origin in animals.
Mm-hmm. Michel Kazakshkin, I will ask you a question that I just got from someone who's watching us. The other problem that we have is that we cannot take care at the moment of the fatigue, of this dramatic fatigue of the medical staff. And we cannot predict how nurses, how medical teams will be at the end of this pandemic, since we don't even know how long it will be. And so is this the next healthcare crisis that we have to get ready for?
Well, I think we're already in that crisis. Medical staff, nurses are already, and particularly in intensive care units, exhausted, tired. And so the crisis is there. There are short-term strategies put in place across countries in Europe, which is, for example, mobilizing a reserve pool of healthcare professionals, some who are in the liberal sector or some who have recently retired. But looking sort of forward, I'd like to mention two things. One is go back to what the other Michel Goldman was saying, which is that we will soon have tests available that will help us know who is now immune to the virus, protected from infection and no more at risk. And that could be, of course, key information for deploying stuff in the coming months. And then there are also ongoing trials of medicines to prevent COVID-19. For example, a trial, you could imagine you would take hydroxychloroquine as a prophylaxis, just as you take this drug when you go to a country where you may be at risk of malaria. Those trials are currently ongoing.
Michel Goldman.
Yes, a short comment. I think it's important to understand that people with a positive serological test not only are protected, but in a way they will behave as soldiers against the virus. Because when you have in a population a huge proportion of these people with antibodies against the virus, they represent a barrier against the virus. Obviously, you need enough soldiers to be efficient. But I think it's very important that people understand that not only they are protecting themselves, they don't represent a danger for the others, but also they contribute to the fight.
Matthias, I have a question based on this, on the economic level. What can we say when people will know who has got the immunity, who has been tested positive for that, and they will go back to work? Do you feel they will have a different way to buy stuff, or that the way the economy is driven at this time, or was driven before, will change because of this containment?
Well, I think, I mean, and of course, as Michel explained, the more immune people there will be, the safer we will all be, and the more productive we will all be, because these people can go back to work. I guess your question is also about what will this crisis change in terms of the organization of society, the behavior of consumers, the producer, and the like. Clearly, one element that could be a double bonus of this kind of thing is that, and we see it today in with this nice technology of Zoom and the like, the fact that we don't necessarily have to move around so much in order to interact, I think will be a plus, also for the planet, by the way. So that's nice. I think this hyper globalization that we have seen, also in terms, the drugs being produced everywhere in the world and assembled and so on, it seems that in terms of strategic supplies and the like, we may want to think about having somewhat more local production.
Yeah, but will it be possible, Matthias? Sorry to interrupt, but will it be possible? Because I know that a lot of people running companies will tell you, of course, we go to China for to produce something, because here in Europe it will be more expensive. So what will the government answer to that?
It is true. It is true that indeed there are good reasons to have globalization in terms of having lower cost products for a given quality. The question is whether we haven't gone too far. And definitely, I think in the health sector, just like in a sense, after the financial crisis, people thought, okay, the banks have to protect themselves a bit more and not rely only on public help coming in case of trouble. Here again, there will be a question about having how much Europe needs to produce of its own medicine and vaccines and the like. Now, we want some, I mean, free trade has some advantages and we have to keep that. But on the other hand, we need to be able to see that that in fact we also have to be self-sufficient in some circumstances. For example, China. Some people are saying that China has managed to win the battle on COVID-19. Well, they are afraid about the virus coming back from outside and are closing their borders. Now, I think if you start doing these kinds of things, that means that hyper-globalization is not necessarily sustainable. So what we will need is a rethinking of the costs and benefits of these different systems, but in a coordinated way. I'm not at all arguing in favor of economic nationalism, but so we need multilateralism and all that, but while making the system more sustainable. Clearly today, we have shown that the system is in great danger. So we need to think about having enough ways that that keep the system from collapsing.
Mm-hmm. Odette, what did you learn from this crisis? Is there something specific that now you will try to work on because you just noticed that it was just essential after such a pandemic?
Well, currently, we have to say we see the same behavior we have seen with other pandemics or epidemics like the SARS or the MERS pandemic or epidemic. There's a lot of defensive decision making. So of course, because governments want to make sure that in the worst, they can care for everybody. We have to see how it turns out. We continue to come up with our claim that we need more risk literate people, more risk literate politicians. We have done several studies with doctors, with patients, with lay people, with politicians, which show that many can't really deal with uncertainty or risk information. And currently, it's not that I would like to play down the pandemic. The only thing I want to say is when you look at it from the risk perspective, there's a lot of things we don't know. And currently there's a focus on a subset of information. So we look at the people with a positive test result. And to this, we compare the number of people who died. And it seems that many more people are probably infected with mild or without symptoms. And so right now we are really concentrating on the subset, and that makes look things really severe. Maybe they are severe, so I have to underline this, but right now we can't really judge because we are lacking, as I said before, we're lacking so much information. We don't know how many people are really infected and how many get along very well. And depending on whether the number of positive tests resembles the number of infected people or the true rate of infected people is 10 times or 20 times higher, the death rate would look different. And also the daily tracking things adds to our fear. So there are several things where we would think at least in citizens, they create an apocalyptic view on the things. And the question is if this is really reasonable or justifiable. But that's an open question.
Mm-hmm. Odette, I have a question for you coming from a mother who is busy with children at home, like I guess a lot of people who joined us today, you of course. Yeah. And so she's asking us if you think, do Odette thinks that young people and young children should be educated to pandemics when they are at school, so very young, like for climate, that it should be the same?
Yeah, it is. Actually, it is the same. Climate change is about understanding probabilities or likelihoods, understanding medical risks, understanding the behavior of pandemics. I mean, all the modelers who do the simulations these days, they're simulating different risk scenarios. Of course, it needs to be taught. And we have developed several nice approaches how you can teach even first graders to start dealing with risk information, to coming up with, in medicine, we would call it the positive predictive value or negative predictive value. So to understand the base rules, so how you can calculate this, and it's not dry math. We really have playful tools so they can play around. And so there are ways, and I certainly would say we need to put a lot of effort, although that is probably not the first thing we think about right now. We should start to put a tremendous effort in educating citizens and start already at school, so that people in such situation do not react with headless fear, but maybe are more reasonable. And of course they behave in a way that it's protecting, also would protect others, so not mindlessly, but would react with less fear. And as you wouldn't see such behavior as you would see right now in Germany, that you can't get toilet paper anywhere. We don't know why people buy toilet paper so much, but they buy toilet paper and pasta. And for 2 weeks we go to the supermarket and you don't get these at all. It is crazy. People behave mindlessly, and I would hope with more education on risk, people would better understand what is going on and behave more rationally, and yeah, with more solidarity also for others.
Thank you. Yeah, toilet paper, if you want to know, that it was exactly the same here in Belgium at the beginning of the containment. And though supermarket had to tell people that there was enough toilet paper for like a year, but though anyone wanted to have it at the same time. So we don't even know why, but we count on you just to know and to explain this to us on next year, maybe. Michel Goldman, I have a question from someone. I guess it's for you, but tell me if you want it to be answered by someone else. What will be the price of the test we are talking about? Will we have to pay it by ourselves, or will it be reimbursed by the state? So whether Marius or Michel Goldman?
I can take it. There are some estimates that, can you hear me?
Yes.
So there are some estimates that the cost of the test would be around 10 to 15 euro. I think the danger with these tests is that people start to order them, to use them by themselves, because the risk, if we use these tests indeed to reintroduce people in normal life, we have to be absolutely sure about the results. So this needs validation, certification of the test. There is still a lot to be done. And we advocate for a centralization, so that for collaboration for this standardization validation. I know that WHO is doing this, but you have also validation studies in each hospital, and they don't always coordinate. It's really critical. You know, again, it's the same virus. The test should be the same wherever we are, I would say, in the world. And I'm afraid that with the current competition, you have probably more than 80 companies across the world developing these tests. So this is competition as usual. And obviously, we don't know what will be the consequences in terms of prices. But what I know is that we lose time.
Mm-hmm. Marius, do you think that people will react positively on this test, that they will all approve the fact that they will have to do it, or will we have problems to test people because maybe they can be scared of the fact that insurances, that government, or I don't know, anyone else who can ask them money or reduce the things they could get from social, that people maybe will be afraid of doing these tests?
I think, as with all other aspects of epidemics, it really depends on the quality of the communication that goes with something new. So, I mean, the point is really when people understand why they are asked to be doing something, and those notions of understanding have just been addressed. The simple math between exponential growth, the simple math behind contact tracing, reduction of contacts. When people understand why they are doing something and that it is in their benefit and in the benefit of the community, then we see that adoption rates are really, really good. So the key is not so much any tool. The key is that any tool is being brought forward with adequate communication and a communication that is adapted to the different type of public. Communication to elderly people is not the same instruments as communication to youngs who are using Facebook, Twitter, or any or social network a lot more. And also, what informs people is also very variable according to the different groups. In young people, they will better will trust official channels. We have to account for those different mechanisms through which communication on public health messagings go through. And that can accompany any kind of new tool that is introduced to deal with the public health problem.
Thank you. We have a question from one of our students of the interdisciplinary program in healthcare innovation. And so he's asking when, and this is going to be for Michel Kazakskin, when this pandemic comes to a close, however long that may be, what should be the first step we as a global community take so that we are better prepared for the next pandemic? We cannot hear you, Michel.
That's a very good question. I would say we need to revise what is called the international health regulations. That is, we need to build a real capacity in all countries to detect, to assess, to report, and to respond to global health threats or health threats that can become global. This is what the world decided in 2005. In 2005, all countries from the United Nations, from WHO, signed a treaty, an international treaty, which is a binding, legally binding treaty, saying that they commit to prepare for the next pandemics and for an ability to respond to the next threats. That has been very helpful. However, recent assessments have shown that only 50% of the countries around the world are really currently ready to detect and to respond to a global health threat. And even as what's happening now in Europe shows that even countries that would score highly in the international health regulations, countries that have potent health systems, were overwhelmed when it comes to taking care of severely ill patients. So we need now to strengthen these mechanisms, invest in preparedness, invest in health systems, and I would say really look at health not as an expenditure as it is always looked at by governments, but look at health as an investment for human capital and for the future.
Odette, I have a question for you, Odette Wekwart. Is it true to say that maybe people will be scared of the quality of the tests? That's a question for someone who's watching us.
Mm-hmm. So I think many people are not aware that tests can be of different quality. That is what our studies show on understanding risk in medicine again. So many think when you do a test and the test is positive, that means that you're positive for certain, or when it's negative, that's negative for certain. So coming back to what Marius and Michel said, so if a test would be available, yes, I agree. If you would like to have people do the test, we need to well communicate why this is reasonable. But before we start to promote such kind of testing, we have to make sure that this test is really sufficient, so that it's sufficient in a way that we would not have too many false positive people and not too many false negative people with the test, so that the quality is sufficient enough not to scare too many people by false alarms, and not put too many people in a wrong certainty that there is nothing or they don't have the virus. So it's we really need to make sure that the test is sufficient enough.
Ici Mathias de Watt répond. Matthias. Or maybe we go to Michel Goldman first. But
Yeah,
I had a problem with my computer, but no, just one point about indeed the acceptability of the test. At first I thought, but maybe somewhat naively, of course these are tests that I would like to do because indeed if I'm immune, then it's great. I know that I don't have to risk or anything. Then I guess in terms of it could be that I'm not immune. So I've never been in contact with the virus. In that case, that means, of course, that if I go out, I take a risk. But moreover, there will be an issue of saying, you know, what if my employer asks me to show this result? And you can say, okay, it's my property, that's fine. In fact, it won't be fine because those who are immune will show it. And then what happens with the others? So in that sense, I think, of course, all these things will be fine in a world where once we have a vaccine, if I'm not immune, I can definitely take the vaccine and it's fine. And but I think we will need to manage the transition because it could create problems of indeed, even in the absence of false positives or negatives.
Michel Goldman.
Yes, but that's all true, but we are not there yet. I think the question of a death is critical. We have some preliminary indication that indeed those tests are rather accurate. So when it's negative, it's really negative, and when it's positive, it's really positive. The point is that the sensitivity of the test is still a question mark. So we might have people tested negative, which actually have perhaps some low immunity. But in terms of using this test, it means that when someone is positive, we can safely say, okay, this person has been in contact with the virus, most likely has cleared the virus, and most likely is protected. To be sure that is a cleared the virus, we have to combine this test with the other classical diagnostic tests. So that's the current situation. The point is that we have to make this validation for all the tests that will indeed enter the use for the mass population. And there is another problem, is to make sure that this test can be produced by the manufacturer in enough quantities. When I see all these companies producing, doing research, some of them will never have the capacity to produce the number of tests that we need.
Michel Kazachkin.
Yeah, just two things on the current discussion, 2 points. One is that, as Odette said, we currently do not know how many people in the population have been in contact with the virus. And in many countries across Europe particularly, and I know here in Geneva, there are now studies in the general population to look at how many people are immune, that is, are positive in these tests for antibodies. And that will help us know the overall protection in the population. So let's say we're in June or July this year, in 2 months from now. If the rate of positivity of immunity is somewhere around 50% or above 50%, then I think we will be close to the conditions of a fairly effective vaccine, and we will not have to worry as much. If, however, in June or July, we find that only 15% or 20% of the population is immune, then we will have to go into the management that Matthias and Michel are detailing. So that's my first point. And a quick second point, coming back to the AIDS experience. It's not only when you communicate about the test, it's not only communication, it is really associating the people who who will be the end users somehow. As you know, we now have self-tests for HIV. These were not tested and then explained to people. These are tests that were in trials, and the trials were designed together with the civil society, together with the people at risk, so that they're then fully understood and accepted by the general population. So I come back to this theme, close the gap between the experts, the science, and the population and the citizens by involving the citizens at all steps, including in the design, the very design of the trials.
Yes, I will go to Odette. I see that you have something to add, Odette.
Yes. So adding to what Michel just said, AIDS testing or testing for HIV is a prominent example. So when they started off in the 80s or in the early 90s to do testing for HIV, the test was pretty poor in terms of a positive predictive value. So about your chance after you tested positive was about 50% that you really had an HIV infection. Over the years, the manufacturers developed and improved this test so tremendously. So now it's a double testing, by the way, which improved it so a lot that now you can very, very certain when you test positive that you indeed have HIV. I think with a COVID-19 test, we are far off the situation. So indeed, what I know right now about the current speed test is that the specificity is pretty high. That means when you test negative, you can pretty certain that you are negative. For the sensitivity, that means does the test really detect these who have the disease with the disease? It doesn't perform so well. That is rather low. So coming then back to what Matthias asked about the situation, this is not a situation where we can use a test for employees or where employers could ask for such situation. And that comes also back to risk literacy. So an employer should understand that a test can create false negative and false positive results. So in no way, unless we have such an excellent test like the HIV test, which is, by the way, nearly the only test which is so brilliant in positive predictive value and the negative predictive value, most of our testing these days are far off, so way lower than this performance. So in no way should a test be a good reasoning for an employer to make a decision. And unless we really can change the sensitivity and specificity rates of such kind of testing.
I have another question for Marius Gilbert, question which is coming from someone else watching us. So Yvon asks us, Marius, we have now enough data from studies in China, Korea to evaluate the number of asymptomatic people. Is it right?
Not entirely. I mean, we have seen some estimates, but they're mostly based on modeling and extrapolation out of modeling. I mean, the gold standard to have really a view of infection in those areas would be serological tests applied through surveys, but we don't have results on that. And even that would be probably an underestimate of the actual number of people who may have been infected, because those tested can only detect the most, I mean, the mild and severe, the mildest cases would probably not be detected anyway. So we can only make extrapolations through modeling. But we have at the moment convergent number of evidences pointing from different countries and studies suggesting that indeed the number of people who have been infected is much, much higher than what we see out of the different testing policies that have been put in place in Korea or even Germany or even China. Yes.
Hugues Bersini, I'm coming to you because we have seen that everyone was collaborating in terms of AI, in terms of informatics. I've seen that many projects were calculating some data all together around the world. People were trying to help them, help their community, but also help the rest of the world. I think you have something to tell us.
Well, it seems we are much more collaborating than medical scientists, because we have platforms like GitHub where 40 million of computer scientists share their work, work together, etc. I wanted to add a little bit because we seems to be a whole worry about this new form of, I would call it algorithmic governance, because as you know, I can say that we're going through a big transformation of our governance, because in general, there are three forms of governance. Basically, just to be short, social norms, laws, and money. And then there is a new form of governance which is popping up more and more, which is this algorithmic governance, and in fact, our democracy are making an important use of it. Look at the road traffic, look at the access to university, look at the access to your taxis, etc. And I think it's a good thing because it's a form of governance which is a little bit more stricter, where you don't punish, but you try to prevent, and it can help a lot. And I think that is an important aspect that, and we need to repeat that again and again, because a lot of prophets, a lot of philosophers seems to complain about this evolution of the society where you have more and more algorithms everywhere to help you to do the right thing. I think this new mode of social regulation is only acceptable at the price of two conditions, and we computer scientists like those two conditions. The first thing, those algorithms needs to be transparent. That's really important. They need to be transparent and known to all. All the people needs to know what governs them, what kind of algorithms govern them. This is not what the GAFAM are doing, because everything the Google, Facebook are doing is fully opaque. We want transparency. And the second thing is even more profound. We want those algorithms to be discussed, deliberated by the people. In fact, Michel Kazachkin was claiming for having more citizens being involved in the decision. And I think the citizens should write those algorithms. And there is interesting platform these days for computer scientists, very open, like GitHub, with, as I was telling, millions of computer scientists putting together, working together, sharing their code, sharing images, sharing radio. And I guess a lot of medical doctors should take example of that. Your micro. Vanessa, your micro.
You're right. Thank you so much. I forgot something very important, my microphone. Michel Goldman, I think it's time now to let people go back to their life at home in containment. I think you maybe have something to say before I give some instruction for the reply and everything.
Yeah, first of all, I would like to thank all our guest speakers, yourself. I think that you did a terrific job, all of you. I would like also to thank those who are, in the backstage, especially Anne Wozniak, Caroline Van Swieten, and Hilde Stevens, who were monitoring what's happening on the internet. Sébastien as well, who was in charge of all the technicalities. Now, I hope that at the end of this debate, those who are following us have still a dose of optimism. I think we have really great scientists, great economists, great people from many different disciplines, and this is what we need. We have to go beyond the usual borders in terms of countries, but also in terms of science. I think those people are there, especially in Europe. So I think that we will have a treatment, as we said, we will have a vaccine. It will take some time. We have still very hard times in front of us, but there is some light at the end of the tunnel. That's one of my conclusion. And obviously, the other is to remind everyone that before we reach this stage, we must be extremely careful, take care of ourselves or our beloved one, and also to use these simple gestes which are so important to fight the virus.
Mm-hmm. Thank you, Michel. Thank you all for your help, for your investment in this debate. Thank you, Michel, and thank you, Mathias de Watripon. Congratulations for this fantastic project. It was just amazing to work with you, because I don't know if people know, but we had to go ahead with all the guidelines, with all we got from government, and of course to respect the rules to protect anyone who had to come. But at the beginning, this was supposed to be made at the Palace of the Academies, and we were supposed to see everyone. So today we are not seeing you, but that's what we expect for the next time, of course. So everyone home, thank you for watching us on Vimeo, on Facebook, on Twitter. Replay of the conference will be available very soon, I mean, in a few hours on YouTube and on the I3H website. We also like to thank the newspaper L'Echo and their website, which decided to stream our conference. And as you know, all of this has been possible, and Michel told it at the beginning, thanks to the I3H sponsors. If you want to follow I3H and if you want to support the independent work of I3H, please join us on I3H website and social medias. One more thing I have to tell you, take care of yourself. Take care of your relative. Next time I will be, and we all will be very happy and very pleased to see you here in Brussels and to meet you for real. Bye, take care.